Thank you. So welcome to the Industry Alliance Symposium. And I think we are now introducing our panelists. Ms. Nikki Oladunmoye is a pharmacist by training with an interest in public health. She currently works at Pfizer, Canada as a medical affairs specialist in rare diseases. Ms. Nikki has a strong commitment to the sickle cell community as her family has been impacted by sickle cell disease. She is very passionate about serving underserved populations and living the Pfizer value of equity. Welcome, Ms. Nikki Oladunmoye from Pfizer, Canada. We also have Ms. Zoraïda, Saoudi, who is a Novo Nordisk employee. She has worked in the rare disease space for the past 12 years, both in Europe, Africa, and North America. Ms. Saoudi holds a master's degree in cell biology from the University of Paris, Descartes. I hope I pronounced that well, but welcome, Ms. Saoudi.
Thank you, Lanre.
We have Dr. Aisha Bruce, who is a pediatric hematologist specializing in sickle cell disease at the Stollery Children's Hospital in Edmonton, Alberta. She is an associate professor at the University of Alberta, and her research passion includes quality of life and investigating patient-directed outcomes. She is passionate about proving quality of life for and the longevity of people living with sickle cell disease. Welcome, Dr. Bruce. Dr. Bruce is also actually the current, I believe, the president for Canadian Hemoglobinopathy Association. So she's a powerful figure, and we're very happy to have you present on this platform. Thank you.
Thank you.
We have Dr. Ewurabena Simpson, who works in the Division of Hematology Oncology at the Children's Hospital of Eastern Ontario, and a major clinical and research interest on health systems improvement for children and adolescents with sickle cell disease and other hematologic disorders. She's also Assistant Dean for the Office of Equity, Diversity, and Inclusion at the Ottawa Faculty of Medicine. And in this role, Dr. Simpson aims to strengthen faculty-wide approaches for supporting a diverse community of learners, staff, and faculty, and to prioritize principles of equity, diversity, inclusion, and belonging. Welcome, Dr. Simpson. As you might know, she's also the co-chair of the SCAGO Summit 2023. So we're very grateful to have her, after all of the work she's done for this summit, to also be a finalist on this session. Thank you very much. We have Ms. Mary Oduwole. Ms. Mary Oduwole's educational background is in biochemistry and environmental chemistry. She works in consulting, specializing in laboratory processes and information systems. She is interested in the opportunity to further SCAGO's mission of raising awareness of sickle cell disease in Ontario and beyond. As you might also know, Ms. Mary Oduwole is the co-chair of SCAGO's Patient Advocacy and Advocacy Council, and she is a family member of an individual with sickle cell disease. So welcome, Ms. Oduwole.
Thank you for the warm welcome.
You're welcome. Last but not the least, we have Ms. Shereese Maragh. Ms. Shereese Maragh is a medical professional who has been dedicated to sickle cell awareness and advocacy through shared lived experiences with the condition. Ms. Shereese is passionate about promoting the betterment of care, research, and treatment of sickle cell disease in Ontario. Ms. Shereese has volunteered for many years with SCAGO in various roles to support fundraising and education around sickle cell disease. Welcome, Ms. Shereese.
Thank you, Lanre.
This is our panelist today, and our topic again is solving the access to innovative therapies puzzle And this is a discussion among clinicians, people with lived sickle cell experience, and the industry. Without taking much more time, we will delve into this discussion. So, starting with you, Dr. Hebe, what do you see as the greatest barrier for Canadian sickle cell patients to accessing innovative therapies? If you can, give us your insights on this question in 1 to 2 minutes. Thank you.
Thank you. And so this is a tough question for me, thinking of the greatest barrier. But what I can say is just looking at Canada and the heterogeneity and size of the country and the way that patients are distributed, not necessarily close to sickle cell treatment centers, this limits the accessibility to evidence-based sickle cell care for individuals living with sickle cell disease, and thinking about how at the present time, not every individual with sickle cell disease can access even hydroxyurea or even has access to bone marrow transplant. It's hard to see how best to facilitate access to innovative therapies, which can have such a profound impact on the lives of our patients, but we still haven't found ways to deliver even the standard of care at this time. So this is where we really need to come together to look at our infrastructure and see how best we can reach everyone in care.
Thank you, Dr. Simpson, for that insight. As our second clinician on this panel, Dr. Bruce, do you have anything to add in terms of what are the barriers or the most profound barriers that you might think of, in addition to what Dr. Simpson has mentioned, for sickle cell patients in this country to accessing innovative therapy?
I definitely would echo Evie's point that geographic is huge, but I also think there's major political barriers, and in that I mean the way healthcare dollars are spread across the country, and being that there's health payments to each province then delineates what people get access to and what doesn't. So there's a lot of healthcare inequities dependent on the province you live in. And I think that when it comes down to innovative therapies, it becomes a major barrier that we have to take into account, because it really is about equitable access for all patients across the nation. And part of our job as clinicians and as patient advocates, and I think as industry, is to find a way around those barriers so everyone who wants access to those medications can get them.
Thank you, Dr. Bruce. Well said. I'll go to our patient panelists, and I'll start with Ms. Oduwole. Any other points to add to what Dr. Simpson and Bruce have mentioned about barriers to accessing innovative therapies?
Thank you. I think of limited availability in general, like accessing even gene therapy or gene editing therapy. It's experimental and in the clinical trial phases, and it's it's restricted to certain profiles at this particular point in time, and it's not widely available. And so that definitely is a barrier. I would say also the high cost for some of these therapies. They are expensive. And so, people become selective as to who they offer them to, only because, everybody has to be wise as to how they're using their research dollars. So then, that's leading to the whole clinical trial eligibility question. There's also ethical and safety concerns that can slow progress. Some patients have dire needs, and really, some of these safety concerns and ethical concerns needs to look at in terms of balancing, in terms of what each individual patient really might need to in order to preserve life, to save life. And for me, I think the last point would be just, lack of awareness. I think there's a lot of times when you want to capture the hearts and the interests of young clinicians to, take up the the mantle, so it were, to continue the research, to continue the interest, and to continue the advocacy. And so it's so important what groups are doing, patient advocacy groups such as SCAGO, in terms of raising awareness and putting faces to the disease, and showing the efforts that are being taken at this particular point in time just to raise awareness moving forward.
Thank you so much, Ms. Oduwole. Well said indeed. And Ms. Maragh, any addition? As someone living with sickle cell, that you think are the barriers to accessing innovative therapies for this population?
Yeah, I do want to add to the to Mary's point about the lack of promotion and awareness of these trials for innovative therapies available to patients to participate in. It's not just for our hematologists to inform us of these therapies or these trials that are going on, but the entire healthcare team that's involved in the patient's care, like family physicians, even during our hospital stay, hospital physicians and practitioners, maybe even social workers that are involved with sickle cell disease clinics. It's all about being informed in your practice so that you can advocate for your patient as well. I would also add the stigma or the label of sickle cell being a Black disease, I feel has added to it not being as prioritized as other life-threatening diseases. And it is really up there in terms of priority, requiring research, requiring funding, and to get these medications pushed out.
Thank you so much, Ms. Shereese. And I want to echo what you said, because I've been part of similar discussions whereby it said that it's been clearly iterated that multiple, like we all have to be part of bringing awareness around what are the therapies and so on. So patient organizations, specialist centers, family doctors, like it's everybody has to be a part of, right? And that will really help to push awareness. But yeah, let's go to our industry panelists. I'll start with Ms. Nikki. Ms. Nikki, what would you say from your perspective, from the industry perspective, as barriers to Canadians accessing innovative therapies where sickle cell disease is concerned? Is there any other point that has not been addressed at this time?
So I agree with many of the points talked about regarding the size of the country, access to clinical trials, but I actually want to state this. Like I think it's fitting for us to acknowledge there's been a shift in the thinking and the attitude towards rare disease. So we know like the government has a commitment to increase funding and access and affordability of effective drugs. So there's been a shift. I think it'll be good to acknowledge that. Of course, we still have other challenges, and as well, I wanted to also acknowledge that Quebec also has like a ministerial policy towards rare disease. So there is a shift, and that's good. And that being said, I think for Canada, from an industry perspective, one of the things that we find is being really able to incentivize like the clinical research coming into Canada, one. And number two, I think really understanding like the reimbursement challenges that companies often face after the drugs are approved by Health Canada for efficacy and safety. So I'm just going to stop there. I think there are many, it's multifaceted, but these are some of the quick challenges that we're seeing from an industry perspective.
Thank you so much. Well said indeed. And Ms. Saoudi, any addition from as an industry rep and the barriers to accessing innovative therapies in Canada?
I think I will echo what everybody was saying in terms of all the barriers that are encountered, both from the patients, their caregivers, but also the clinicians and the healthcare system. And I also agree with what Nikki was just saying from an industry perspective. I think one of our roles is really also trying to develop and make new effective and safe disease modifying therapies or new innovative therapies to patients. Through clinical trials, through compassionate use programs, whenever those molecules reach the market. But I would like also to emphasize and just maybe stress the clinical trial points, because one way of accessing new innovative therapies is through clinical trials. And the timelines for setting up a clinical trial are also very, very long, very complicated, in terms of, approvals from ethics committees to everything that's pertaining to the setup of a phase 2, phase 3 clinical trial, patient, awareness, clinicians as well. So I would say that one of the things that we are trying to work on is making as much clinical trials accessible as we can to patients, so that they are aware of what's also being developed, trying to include as many patients as we can as well, because it's often limiting. And one of the panelist members also was talking about the very tight inclusion criteria. So that's something we are also trying to work towards too. But I will stop there as well. But I also agree with everything that's been said before.
Thank you so much for that insight. So there are many barriers, as we've said, but there are some strides we have achieved as well. As Ms. Nikki pointed out, federal government has committed 1.5 billion for rare disease strategy in this country. And I think by having this type of conversations is how we can really make sure that some of that money comes to sickle cell, support sickle cell disease, right, across the country. Otherwise, there are so many rare diseases, and some of them are very costly, and we might not see any of this money. So, like, I think Dr. Simpson mentioned that in the beginning, to say that we must come together, to solve these issues and make sure that patients with sickle cell in this country have access to innovative therapies. Thank you so much, everyone. I'll go on to the next question, and I'm directing this question again. We're starting with the industry partners. And my question would first go to Ms. Saoudi. And how can biopharma and the academic or healthcare provider community better partner with advocates, with patient advocates, patient organizations, to help improve access to innovative therapies in Canada? So how do you see that partnership to be effective? How do you think it can be effective working with patient organizations
I think
from the industry perspective?
I really think that forums like today's one are very, very important, because I think that we need to listen and hear each other's voice, and also try to understand where we come from, so that we may help each other. I think we cannot work without the patient, advocacy groups. We cannot work without the clinicians and with all the stakeholders that are working. So I would say that forums for discussion, for setting up action plans to better help each other, so that we can advocate for the same thing and achieve a common goal, which is really bringing those therapies to patients. It was said earlier from Dr. Simpson that even standard of care is not accessible to all patients across Canada. So that tells a lot about, yes, the systemic issues that we are encountering, but I really think that hand in hand, forums like this one will enable us to have strategies in plan and actually execute them for the best of the patients. Yes.
Ms. Nikki?
Can you hear me?
Yes.
Okay. It's a great question, realizing that, we're all pieces of the puzzle, industry being a piece. And I think it's really important that that we advocate alongside all the respective stakeholders, academia, research centers, to drive policies that support, I would say, for example, competitive regulatory incentives, like thinking about rare disease as a whole, to support policies that help to bring increased diagnosis for patients, screening for patients, that help to improve access to innovative therapies. I guess to one of the points that Zoraïda made was around clinical trials, ensuring that, that we have a competitive environment here that incentivizes companies to want to bring clinical trials into Canada, and also like ensuring that the policies that we're doing is cohesive So if I'm fighting, if we're, you know, advocating for a cause, that the cause I'm advocating is also supporting what academia is advocating for, and to ensure that patients get access to drugs, right? That's the endpoint, is to get better outcomes for our patients. So I think really understanding what everyone's imperatives are and really working together cohesively on policies that move forward, excuse me, that move forward patients' access to to medicines.
The SCAGO has the Industry Alliance Symposium. What would you say is the role of that kind of initiative in ensuring that the biopharma, the academic community partner with advocates on improving access to innovative therapies? If I may ask you, Ms. Nikki, yes.
So I actually enjoy attending the industry, like the IAC, because everyone's there, and I think the focus is on, you know, what are we doing to move things forward together. I think that's important, right? So I think the IAC can bring the issues that maybe academia is facing, or things that we might not necessarily be privy to that forum to discuss and see how we can move things forward. Like I actually enjoy attending the IAC, and I'm also always learning as well, like what are the challenges that other pharma companies have, like what are the projects the community is working on, how are we able to support the community, even if it's you know, internal or like expertise wise, like how are we able to support through the expertise that we have as industry, or the experience we have as industry, to ultimately better patient outcomes. That's the end point, like the better patient outcomes. We want our patients to, or not patients, or the community to have medicines that help improve their lives, right? So I think it's a good forum to bring whatever the different issues are across Canada, because oftentimes it's hard to have that Canadian perspective because we're so far, you know, we're so widespread. So I think the IAC it's a perfect forum to bring the topics to the table for discussion and also deliberation, and also like offering up whatever expertise we're able to provide to the community, right?
Thank you, Ms. Nikki. I will ask the healthcare providers the same question, starting with Dr. Bruce. How can healthcare provider community better partner with patient advocates and the industry to ensure improved access to innovative therapies in Canada?
It's an excellent question. I think we all face very similar barriers: time, money, all of those kind of things that stall us up as healthcare providers. In terms of, when I mean money, I mean like resources within our clinics, and for physicians, just we're underrepresented as in healthcare as the number of providers to patients even, right? So those sorts of things make it difficult for us to ensure that we're partnering well with industry and such, but we need to be there. Things that bring this to light are a lot of the medications that are very available in the States are not necessarily available here. We can't bring some basic medications, I would call them fairly basic medications, being that they're FDA approved now, to Canada yet, because we haven't passed those processes. When I talk to industry, a lot of it is about the timelines and the process for Health Canada. So I think as a group, and including with patient advocate groups, because your voices are heard more so than I feel like ours are, which is a very appropriate thing, because you guys speak from the heart, you speak from the place of living, having the lived experience, and we can bring the medical expertise. But I think together, if the three groups are not together, we will not get past these barriers. So I think it's essential, and two, I think, what can we do? Really, I agree with Nikki. It's forums like this that are essential for us to talk and listen, and hopefully hear each other's barriers, because I hear the need for novel therapies, and I hear the need for access to care and the cost of medications for families and for patients, and then how how do we approach those and how do we advocate together, really, because our healthcare system is public, through the public system, and get access to those meds. It really comes down to CADTH and places like that to approve these medications after they're approved through clinical trials. And then how do we advocate through CADTH to make sure our patients have access to these meds even? And that is very important. We have to be able to access these patients other than on special permissions on a per patient basis, right? So
thank you so much. Dr. Simpson, you would like to chime in?
Sure, thank you. And so I agree with the most of what has been said already. And so a couple of things that I wanted to comment on. So in talking about, patients, healthcare providers, and industry, we each will have our organizational goals and mission, but I think it's really important that we, as Nikki alluded to, have a really clear understanding of the role that each of us has in advocacy, so that there's no duplication, but where we have overlapping vision and overlapping goals, that we really leverage each group to make sure that we're able to really capitalize on opportunities to work together. And I think that although, we're all, short on time and resources, I think it's really important that we have fora that break down those silos between the three groups, like has been said already. I think it's great to have a venue like this where we have the opportunity to come together, but we have to keep the conversation going. It's not enough to meet at a conference and share the ideas and, having recurring meetings, but also having kind of longitudinal meetings where each meeting is a means to an end and it's clear where we're going, I think would be so helpful. And that way it'd be possible to give each stakeholder or each of the groups like a specific role in moving the agenda forward. And that also helps engagement. If we all know what piece of the pie we have and what we're bringing to the table, I think that it really will help us to move forward as a group. But
that is so well said. Thank you so much, Dr. Simpson. Ms. Saoudi, any comment on that? Any addition?
No, I just wanted to comment on the Industry Alliance forum, actually, because what I also enjoy is also that we are trying also to understand what we are doing now and how we can move the needle and using each and one of expertise so that we can help each other in solving what's now. And all these baby steps, small steps that we are doing are also heading towards that bigger role, bigger actually goal. So that's something that I really enjoy with that, having the opportunity to learn from all that are attending, but also put in my knowledge, my humble experience in serving the now in the hope of building a better future.
Thank you so much. Ms. Shereese and Ms. Oduwole, if you'd like to chime in, you're welcome to.
Sure, I just want to state that I agree. I think collaboration is so important. And I think also in terms of approaching, I guess, this conversation from a parent's perspective of a child who has sickle cell disease, I think, transparency is just so important in terms of where things are at with, with these technologies and these therapies, and building on trust moving forward is just so important to stay engaged and to just to continue to collaborate. So for me, collaboration and looking for opportunities for partnership is just everything at this point.
Wow, that's so powerful. Thank you. Ms. Shereese?
Yeah, I agree with all that was said. Collaboration will definitely help patients feel in the know a little bit more about what's going on in terms of clinical trials and medications that are under review or FDA approved. I think it would also increase willingness of sickle cell patients to even participate in clinical trials, because I know participation is huge in getting some of these trials pushed forward and funded for. So yeah, just the communication around everything would definitely push the whole agenda forward.
Thank you, Ms. Shereese. So well said. And that would take me to the next question, which I will start with you back, Ms. Shereese. Now, my question to you would be, what should academic and industry researchers do to ensure that the different perspectives, experiences, and preferences of patients are incorporated into the development of innovative therapy? So what should be done that you might think is a gap, it's not currently being done, that should be done and should be incorporated into the development of innovative therapy?
I'm sure a lot of these things are already being done, but I definitely want to strongly encourage that more interaction with patients. So even like face-to-face interviews, either through one-on-one telephone calls or virtual meetings with patients, or even small focus groups with sickle cell disease patients to get their input. Maybe even reaching out to social media small groups or peer groups. Like I know SCAGO offers a peer group where patients come together and they discuss their lived experiences and provide support for each other. So, you know, having even a researcher attend one of these sessions will allow them to obtain some insightful information and understanding. Or even just involving researchers with actual lived experiences as a part of their team. They would come already with a wealth of knowledge and understanding of the disease, so they'll know exactly how to make any impact or changes to these innovative therapies. And then lastly, as this was already mentioned, but attending summits like this or patient-led learning sessions put on by awareness groups like SCAGO or sickle cell associations or those across the globe is important.
Thank you very much for your insight. Ms. Oduwole?
I agree. I just feel like just having the patient at the center of all that is driving the research and driving the technology, increasing feedback opportunities to get that perspective right from the beginning all the way through the entire research process is just so critical. And so I'll just leave it at that.
Well, I really I agree with what you both have said. And I know we have had similar discussions whereby patients also have also said that having patients in all aspects, like you mentioned, like in governance, not just to be a part of the clinical trial, but in the planning stage, in governance, in every aspect, will really drive, number one, trust of that trial, and will ensure more patients participate. It will also eliminate what we call tokenism, whereby patients might feel like, okay, they just add us along the line, just to show that patients are involved or engaged, but are we truly engaged? Are we truly involved in this trial? I think these are some of the things that we have heard from similar discussions, but I want to throw this to our clinicians to say, is there anything else that you think, should be incorporated in order to ensure that the patient's perspectives and experiences are incorporated when industries are developing innovative therapy?
I could go ahead if that's okay. Or Dr. Bruce, do you want to go ahead?
Sure. Dr. Simpson, you can go ahead. Yes.
Okay, thank you. And so, I mean, I would just echo what Ms. Shereese and Ms. Maragh have said already, in that, there's this saying nothing about us without us. And I think that holds true for research, where, in designing the study, in designing or when thinking about the drug development even, I think there are opportunities to engage individuals with lived experience earlier on than at the clinical trial point. And, to again, talk about the example of clinical trials, many of these trials are designed based on context outside of Canada in terms of how they're structured and how the follow-up's delivered. And the structure of healthcare centers in Canada is very different from the US even. And so, for our center, for example, when we were involved in the River Pencil Reset trial, it was challenging because we didn't necessarily have the structure that the study design called for, so we had to improvise. And that makes it difficult for the investigators, but also difficult for the patients to be participants in the study because of differences in our environment. So I wonder, and I guess it's being aspirational. I heard that word used a lot today, and I do like it very much. But perhaps there is a way that in designing clinical trials, there's a way to design it specifically to the context that you're coming to, like for by engaging patients in the design, engaging clinicians in the design, and that's a way we can partner to make sure that the trial is more accessible to patients, but then also continue to partner when it comes to advocating for drug approval and reimbursement so that it's feasible and affordable for patients to be able to access these medications and novel therapies.
Thank you so much. So your comment truly, and Ms. Oduwole and Ms. Maragh comment truly echo what Ms. Nikki said initially when she said that we are all pieces of a puzzle. So which means we have to work at it together at every stage. I'm going to pass it to Dr. Bruce if she has any other comments to add to that. Thank you.
I do. I think it's all been incredibly well said about how trials and research should be designed with patient advocates from beginning to end. I don't think I think that is not only the gold standard, but what needs to occur across the board for anything from a simple survey right through, because truly you need that voice. Because it's actually, I think, a bit inappropriate without that voice. Those are the voices that we're designing the information for, and they need to have input. What I would say for just even for, and this is a little off topic, but for healthcare providers, I think healthcare providers and industry, what if I'm not opening a trial, but it's available in Toronto? If industry, that's great, as long as I'm aware that my patients can still go to Toronto and that they don't have to pay exorbitant amount of fee to stay in Toronto, live in Toronto, to be part of that research trials, that the cost for them is free to go back and forth, or covered, I should say, reimbursed. Because sometimes I don't, like our center has the infrastructure, but Saskatchewan, for example, if you lived in Saskatchewan, and those are the geographic boundaries, but honestly, I don't know all the trials that are happening at Sick Kids. And that is unfortunate. And so that is a barrier to me, because there are trials that Sick Kids has open that I don't have open, that my patients should have access to, right? So maybe it's not feasible for industry to open it everywhere in Canada, but if the family is willing, or sorry, I'm a pediatrician, so if the family is willing to travel, great. Or if the patient is willing to travel, great. But we should at least be able to offer that to the family. And right now, most of the time it is not. Well, sorry, I'm not aware of it, so therefore I can't offer it, if that makes sense. And that's a bit about healthcare communication around, like more at the healthcare level as well as at the industry level, just letting us know that the trials are open at these sites. And that would be, I think, very powerful. It's powerful for my families to hear in clinic that there are trials open. People care. People are studying this. They want to make the lived experience better. And just hearing that sometimes is reassuring to families, that we're not just saying, here's hydroxy and that's all we have for you, right? That we're like, there is stuff, it's coming, we're trying, right? Like, they need to hear that, they need to hear hope. And this is part of it. It might not be the trial for them, and that's completely fine and acceptable. But I don't like the fact that I can't access certain things, but yet it is available in Canada somewhere. Sorry, that's a totally off topic
Oh,
thing.
no. That is actually a great addition to this discussion. And I can tell you, like SCAGO on our website, we do have a list of all of the trials that are available in the country. But maybe what we need to do is that through IAC, which is supposed to be a pan-Canadian initiative, ensure that, you know, all centers, this is what's happening. I know like last 2 weeks or so, we got from UHN what is available. Maybe we have to approach all centers to submit what they are doing and make it available for everyone to be able to have access to. But that's a very good addition. Thank you so much for bringing that point up. Again, if we are all a part of a puzzle, and I think it's Ms. Oduwole spoke about transparency, we all need to know what's happening. Left hand wants to know what the right hand is doing for us to be effective in the work that we all do. So thank you so much for that. We have to be more, like you said, communication. Communication has to improve on what's available.
I think a piece of that is the transparency around cost for the parent or the patient or the family, because it's not cheap living in Toronto for a couple of months, as we all know. So
Yeah.
for a family to travel across the country or something for that trial, we'd have to be fairly transparent that there's cost of funding available or there's not, right? Because I don't want to offer something that the family is excited about, but then can't access.
And this is something that maybe we can bring up in the next ISA meeting that happens every 3 months, and to discuss how do we, if something is happening, is available in one center, how do people in another province, right? You know, how do they access it, right? And what are the barriers, like you said, accommodation, feeding while they are there? What can be supported and what cannot be supported? I think we need to have this discussion. It's very important. And I'll note this as part of our agenda item for the next IAC. Thank you so much again, Dr. Bruce, for bringing this point. It's very important. If we are talking about improving access to innovative therapies in Canada, we've got to talk about these things. It's very important because these are clearly barriers, right? If we don't have the communication, we don't know what's available. And when you have communication, families cannot even access, right? Because of inability to maybe stay in a different province or something like that. So these are very important points. Thank you so much for bringing that up. I'd like to go on to the next question, and that I am addressing the industry partners again. We've heard a lot about how we could work together, but we also do understand that industry has guidelines, healthcare providers have guidelines that guides them. And I'm just wondering, within your guidelines and what the protocols, what you're allowed to do, is there anything that we have not discussed that we need to talk about, that we can work together on to expand access to innovative therapies in Canada that was not yet talked about? Is there anything from the industry? And then I'll ask both the doctors on that, and then our patients can chime in.
I guess I could take a stab at this. Something that comes to mind is, I guess, along the lines of clinical trials, and in this, I guess, in the space of rare disease. Oftentimes, in some diseases, sickle cell inclusive, like the natural history of the disease is something that might still be evolving, or pathways of understanding how like therapies work might still be evolving. And so oftentimes in some clinical trials, like the endpoints that might be looked at might not necessarily be what's reflective in clinical practice sometimes, or what is feasible to be measured in clinical practice. So I think one of the things that as industry, we could kind of work closely more with academia is really understanding and collaborating on endpoints that, one, make a difference for your clinical practice, that you would see is valuable to your clinical practice, as well as considering where health technology market in Canada, like being able to satisfy the requirements of the payers, and of the payers more importantly. So I think one of the things that maybe we haven't really talked about is collaborating on like especially when I think about rare disease as a whole, on the endpoints that are meaningful for the patients, meaningful in clinical practice, as well as satisfying payer needs.
Thank you. Before Ms. Saoudi speaks, I want to tell our audience today, if you have questions for our panelists, please put it in your Q&A box or the chat box, and we will take those questions shortly. Thank you very much. Ms. Saoudi, is there anything else that you can add? Thank you.
No, I would echo what Nikki just said. I think conducting, patient-reported outcome measures, studies and but also surveys within the health with our clinicians is very important, because it will help also design those clinical trials to make them relevant, to answer those needs. And what Dr. Bruce was saying earlier is that also patient voice is very important when it comes to payers, because it's one thing to have Health Canada approving one molecule or one therapy if it is not really accessible to patients. That make it not redundant and not something that is accessible to them. So these patient voices, and there are a lot of barriers in terms of what CADET or what INES are willing to listen to and take into considerations in their evaluation, so that they may list one therapy versus another. I think patient voice and clinician voices is one thing that is very powerful, but I think that having reliable data, we cannot always have them in clinical trials, not always able to measure them. I think it's really important to create and work together with you in establishing a channel so that these voices are being heard when the product reaches the market, for it to be accessible to patients.
Very true. Thank you so much for that insight. I will pass this on to Ms. Mary for your comments on this.
I think for me, with regards to clinical trials and rare disease in general, getting a representative cross-section in which to do the clinical trial is so important across genders, age. Historically, clinical trials has largely forgotten in terms of its numbers and enrollment and representation, the Black community. And so when we're looking at, innovative therapies for sickle cell disease, I just, as a patient, want to stay focused on the fact that it's not just, a Black person's disease. It affects there's many people in different ages that can probably benefit, and that we would want to study that as well, so that we can offer, when these therapies become available, it can be offered to a nice broad section of the population. So I think for me, just being, just remembering the diversity aspect of the clinical trials is just important as well.
Thank you so much, Ms. Shereese.
I think it's all been said very well. I will just echo what has been said. It's really important to have that diversity, because, as we know, as Ms. Zoraïda said, that the exclusion criteria for a lot of these clinical trials is big. I mean, things like not receiving blood transfusions or having kidney disease, renal failure, being on or off hydroxyurea, which a lot of patients cannot be on or have had terrible adverse effects from that. So I think it's very important that these things are looked into when exploring clinical trials and the types of innovative therapies coming up.
So just from your comments, you're saying we have to also carefully look at the exclusion and the inclusion criteria, because that also could become barriers for many people. Very well said. Thank you so much. Well, we have the closing panel question, which I'm going to ask everyone. And we have one question in the Q&A box. Please, folks, keep your questions coming. Thank you very much. I'm going to start with Miss Mary Oduwole, and I'm going to ask you, if you had a magic wand and you could solve or address only one issue or challenge or barrier of access to innovative therapies, what would you choose to do? If there's one thing you can do, what would that be?
I would have a bag of money and eliminate the financial barriers.
You solve all financial barriers. That's exciting. We love that. Money is always a good thing because money solves a lot of problems. Not all, but most of the problems. Thank you so much. And I will ask Ms. Shereese, what would you do if you had a magic wand and could solve or address only one significant issue? What issue would you solve?
I definitely had money in mind, but I think another barrier is the label around sickle cell disease as, again, being a Black disease. I feel with the population changing, it's becoming more diverse, more mixed. There are a lot more people with sickle cell disease, not just Black people. And so I think that is important for when they're considering it on a provincial level, that it's affecting more of the population and not just a small group of people.
Wonderful. So you like to solve the stigma issue? Stigma, discrimination.
Absolutely.
And Ms. Oduwole would like to solve the monetary problem associated with sickle cell. Okay, that's so good. Okay, I am going to go to Dr. Aisha and say you got this magic wand, and it's only one barrier or challenge or issue around access to innovative therapies. What would you do with that magic wand? What problem would you solve?
Sorry, who were you asking?
Yourself, Dr. Bruce.
Oh, sorry. Sorry.
Don't worry.
I would say, like, I have to agree with everybody, everything that's been said already. I would call it's often the process, and with that goes the communication. It's the amount of paperwork and processes that are very, very slow in Canada compared to other countries that make us somewhat unattractive to our industry partners, because it takes so long to get things approved that it becomes a bit of a barrier. We are, I have heard, good about bringing in clinical trials, but still not attracting many because of these barriers. And it really is about different layers of approval and how slow each layer takes. I mean, it takes over a year in my center to simply get through the processes to open a clinical trial, right? And that is with a research assistant while working full time on the processes and the paperwork and waiting for signatures. And so it's just this whole load of paperwork that goes behind all of these studies. And there is no reason that cannot be streamlined in a safe and effective manner. So that is a piece of, it is partly communication, but it is also a huge barrier, I think, for industry, for us, and for patients on the receiving end of not getting clinical trials open because of that.
Thank you. Well said. Dr. Simpson, what would your magic wand do? What problem are you solving for us? Thank you.
So if I had a magic wand, I think one thing that I would want to accomplish is increasing the expertise for caring for individuals living with sickle cell. So that means by having an increased number of clinicians and allied health providers who have the skill set and knowledge and compassion to deliver this care so that we can reach more patients. And you don't have to necessarily travel long distances because you can find somebody with that expertise wherever you are. That's good.
That's amazing. Okay. So industry partners, starting with me, Zoraïda, if you have a magic wand and you can only solve one barrier or issue or challenge to improve access for sickle cell patients to innovative therapies, what would that be?
Thank you, Lanre. I think it's a very good question. I listed a couple of things actually that I could, because I knew that there will be other panelist members that will, definitely talk about one of the things that I've listed, and you talked about them all. So can I say all of the above? Obviously, yes, all of the above is true, but I would say also being making that people are more open to hear each other, to hear what others are living, what patients are living, and how we can work together to make sure that we are improving policies, that we are improving healthcare system, that we're improving everything. So that I would say magic wand would be yes, willingness to put ourselves in the patient's shoes, in the clinician's shoes, and really understand what is going on, so that we can take it our own it, and work towards just overcoming these barriers.
Well said. Thank you so much. And Ms. Nikki?
Mrs. Lanre, honestly, I wish you asked, I wish you didn't give me the magic wand, but you gave me the genie and I had 3 wishes. That would have been better. But I'll take the magic wand and just one thing I would like to solve. I think it's important that we have like really agile and predictable, like to Dr. Bruce's point, efficient and consistent ways of approaching how we talk about and bring drugs into the rare disease space. So I think that's one of the key challenges that we're seeing. So being able to understand that the urgency is a bit different and that the options are very limited in the rare disease. And so the processes that exist for other drugs or other diseases would have to be changed or tweaked to accommodate the fact that we're talking about rare disease here. So, so if I did have a magic wand, I'd say I'll focus on ensuring that patients across Canada, to Dr. Simpson's point, have equitable access to care and drugs, and that that the reimbursement process is not so delayed, and also that there's incentives for companies to come into Canada and actually, bring innovative therapies into Canada. So I guess my short version of if I had one wand would be to help increase access.
Thank you so much. That is so well said. Now we have 2 questions in the chat box, folks. You can keep bringing your questions. The first question says, diversity in terms of the subject as well as the researchers. So that's what the question is about. How can industry proliferate the representation of underrepresented folks in the role of researchers, investigators on clinical trials? And I will let Ms. Nikki lead us in that question. Thank you.
It's actually it's a tough question to answer. It's a great question. So I know different companies are encouraging. I guess if I think about this question, really, it's going down to, I guess, STEM, like having access, increasing access of underrepresented people into research, right? So I think it's a bigger piece than industry alone is able to solve. I think it's more like a larger picture of the educational system, but like I'll say, I know different companies have different initiatives to go into schools that are historic Black colleges or schools, or reach out to open up opportunities to people who are underrepresented to come into the industry and to get into areas that they haven't been typically exposed to. So I know different industries do it differently, but I think the question it's like bigger than just like an industry role. I think it's more it's probably more systemic.
Yeah. Mm-hmm. Thank you so much for your answer. Ms. Zoraïda, your insights on this question?
I agree. I think it's a very interesting question. I think all these pieces of the same puzzle have a role to play in making sure that underrepresented people are actually participate in investigator research and clinical trials. I think one thing that we can do, obviously, from an industry perspective, is really learning, programs that are really patient-centered programs and research. We talked about it often earlier, is that involving the patient advocacy groups, involving the patients early on when the clinical trials are being designed at early stages will also ensure that their needs, their preferences, that their voice are being heard, and so that will ensure in a way that they are also included in this investigative research. I think we all have a role in playing to play in that, and I think what our piece would be, yes, to include the patient more. Establish patient advisory board, conducting, as I said earlier, patient-reported outcome research, actually communicating on the results of the research as well, so that it help also design future clinical trials as well, making sure to collaborate with patient advocacy group, with clinicians as well, having a transparent communication. That's something that's been talked about a lot earlier, but also act on the patient feedback, following those meetings and those forums where we are discussing clinical trial design. I think it's also important that we as pharma, whenever we are designing those clinical trials, act on the feedback that is being received. And it's been also talked about earlier, but I think also ensuring that the diversity of the patients is key here. So regardless of the social economic level of the patient, or their gender or the age or geographical location, I think it's at least what I see pharma helping there.
Before I ask, okay, Ms. Nikki, you want to chime in again? Sure.
Right, and I think I wanted to also address the question when it comes to because the question, I guess it's twofold. So diversity in terms of the subjects and diversity as in terms of researchers. So I think I addressed the question of diversity in terms of researchers. And as far as subjects, oftentimes when clinical trials are done, I think there's an effort to go into the community. So go into the patient advocacy group, through the patient advocacy groups, go into the communities where patients, where the potential participants live and work, and ensure that the clinics or the sites are set up there. So there's convenience, you don't have to travel far. It's kind of close to home or close to school or work or, place of worship, right? So I think there's like an effort that has been made on the industry side to ensure that the research centers or like the clinical trial sites are kind of closer to where the potential patients or subjects might be.
Thank you, Ms. Nikki. Dr. Simpson?
Thank you. I just wanted to add to what's being said, because I do agree that, there's a more systemic role at play in terms of, the pathways for becoming scientists and investigators and having diversity from that perspective. But in the short term, I wonder if there's opportunity to engage scholars who deal with or who are experts in areas related to the impacts of anti-Black racism, for example, on health, as part of an advisory committee, not necessarily somebody who is a medical scientist or physician, but somebody who has expertise in that specific domain, in trying to lend that expertise to help to better recruit and engage patients from specific communities. Because again, I think we're so used to working in like certain lanes or consulting with certain groups, but I think that, thinking about the societal impacts and influence and talking about systemic issues that limit our participation or engagement of patients, we need to think a little bit more broadly, and engaging people who have expertise in those domains would be helpful.
And just before Dr. Bruce goes on, I just want to echo what you said, Dr. Simpson, because I remember, I can tell you even her experience as the SCAGO between 2005 and 2010, when we survey our patients, many of them don't want to be involved in clinical trials because, again, there is the anti-Black racism, there is the mistrust. Everybody still remember the Tuskegee study where Blacks were used as guinea pigs. And so people were like, well, we don't want to be part of that. Well, we let the pharmaceuticals develop their drugs, and then if it's good, we use it. But we don't want to be guinea pigs for any drug. But then when we saw that that was the attitude of our community, and you can't blame anyone for being that way because of the historic, happenings, right? What we did was a lot of education around clinical trials. This is your right, and you can, if this study does not align with your values, you don't have to be part of it. If you are in a trial and you feel like you need to, this is not aligning, this is not good, you can get out of it, and we did a lot of, education around that. And now when we survey our families, what we're hearing is, where are the trials? Because now the narratives has changed because we made our patients to understand that they are in control, and that there are guidelines that have to be followed that would never make something that happened with Tuskegee happen again, right? So a lot of that also comes with, so I think, trust is important, anti-Black racism and all of that. There's a lot of experiences that people have lived through or heard about that have made them made up their mind in one way or the other, but it's about transparency, like we talked about, communication, education, awareness, all of these things I think can also be helpful. But I will let Dr. Bruce, chime in on this. Thank you.
Thank you. I just wanted to say, I think we all would agree that this is essential. It's essential to have more diversity in all our spheres, truly. And what diversity represents, I think Shereese has stressed well, that it represents many things, diversity, but it needs to be included at all levels in the universities. And from lived experience, I can say, you don't want to walk a path unless you know someone else has walked it before you, right? And that's from my own lived experience of being a single mother and going through medical school. Unless I saw someone walk that path, I didn't want to walk it myself. So we really need to do that. And as individuals, we need to do that. We need to mentor people from diverse backgrounds, helping them through whatever career path we're on. We need to do it in every single way we possibly we can. And I think it's just something that we can't let drop because it has momentum now. And I just don't want it to go away as an issue for society. We just have to keep pushing it and keep raising it as an issue, and keep mentoring and keep helping people, or giving them opportunities that they might not have had access to because of just the availability to them in whatever life circumstance they have. So I echo all your points, and I'm glad the question was asked. Thank you.
Thank you. This next question comes from someone that is not from Canada, so joining us from Nigeria. The question is, how can access to new therapies be fast-tracked to reach folks with sickle cell disease, no matter the geographical location? So I'm guessing this individual is asking this question because, for instance, we have less than 7,000 people in Canada with sickle cell, whereby countries like Nigeria has a lot of people with sickle cell, millions of people with sickle cell disease. So what is the plan to ensure that, low and medium resource countries also are able to access new therapies fast enough? Are there any plans around that? So we'll let Pfizer representative talk first. Thank you.
It's an interesting question. And when people ask that question, what keeps you up at night? It's one of the things that keeps me up at night, knowing that in North America, we have the best innovative therapies. I think for gene therapy right now, for sickle cell right now, we're talking about, CRISPR, and there's all this amazing work that has been done that we know for sure it'll take a while to change the standards of care in other low to middle income countries, right? So it's one of the things that keeps me up at night on a personal level. But I think for fast tracking, there are different ways of, I guess there are different commitments from different companies. I know some companies work closer with the local governments or the federal governments to ensure that innovative therapies come into the country at a, you know, I don't want to say discounted rate, but like at a lower cost to the country. And as well, like you also have to think about each country has their own regulatory process. So I think that's something that we shouldn't forget. So I know I'll give an example. I know Pfizer has a commitment through their Accord program to ensure that countries that are low to middle income get access to the best and the greatest therapies that are available in other parts of the world. So that's a Pfizer commitment. And I know other companies have different programs targeted to, maybe maternal health or, different programs, right? So I think there are many factors to consider, because at the same time you want the drugs to be approved by your regulatory agency for safety and efficacy before it's used. So there are many I guess barriers to fast tracking, but I know that companies are aware of the aware there's a inequity there, and they are making commitments to ensure that where you live in the world doesn't affect the kind of care you should get. So companies are rising up to this challenge and are tackling it in different ways. And I can only give an example of what Pfizer is doing with the Accord program. I'll let Zoraïda answer to see what's happening with Novo Nordisk.
I think this is a great example of what health inequities look like, in other parts of the world as well. I also come from a country where it is considered as a low to medium country. It is Algeria, so that's in the north of Africa, and we are also impacted by sickle cell disease and thalassemia a lot in my home country. So I think that a global collaboration is something that's really important, where we need to foster, these international collaboration among researchers, healthcare providers, policymakers, but also share the findings from the research that we are doing, but also the best practices in treatment across the world. One thing is also important is simplifying regulatory pathways. Each country, as Nikki said, has its own regulatory pathway and processes. So that's something that needs a little bit of streamlining and more, expediting of regulatory processes. Public-private partnerships, I think, is something that is really important for encouraging partnerships between the governments, the pharmaceutical industries, and the nonprofit organization as well, that are often having a huge role in these countries as well. One thing that Novo Nordisk is also doing, that we are seeing across all therapies that we also have, is having a flexible pricing model. And that's really important, because when you want to also market any type of therapy in any country, you cannot have the same pricing model for each country. There are a lot of factors that you need to factor in, and that's something that Novo Nordisk's been doing a lot, along with compassionate use programs. So what we do as part of facilitating access to innovative therapies is compassionate use programs and donation programs that we do in rare disease as well. One the example that we have a lot is in hemophilia, the hemophilia space. That's been through the Novo Nordisk Hemophilia Foundation, and also the work that's being done in all these countries as well. And I think also having support from the governments is also important. So as pharma industry is also trying to advocate and lobby for with the governments to be able to make these therapies available there.
That is well said. I just want to also add that the Global Action Network for sickle cell and other inherited blood disorders is also working to ensure that clinicians and researchers in low and medium result countries have right mentorship programs that they can tap into. And we hope that also will help in this quest to ensure that clinical trials and research get to low and medium result countries sooner than later. Thank you so much. I think Ms. Nikki has her hand raised. You can talk. Thank you.
All right. Another point is I think one of the things that we also have to keep in mind is building the infrastructure there. So building infrastructure and expertise, to your point, Mrs. Lanre, is very important to sustainability of these systems. So it's not just enough to, develop send the drugs there, but actually building the local expertise of the clinicians and also the system to be able to sustain over time, even after the public-private partnerships end. I think that's super important to note.
Thank you. That's well said. Second question will be directed to Dr. Hebe. How do you think sickle cell disease care and management will look like in the next 20 to 25 years? Where do you think it will be as a clinician?
Right. So how I think it will be, or how I want it to be.
And where is that?
Okay. Well, I think, I'm very inspired by the momentum that we have, as Dr. Chris was saying, in terms of bringing the stakeholders together and trying to improve care for sickle cell disease and for individuals living with the condition. And where I see the management of the condition in the future is that we'll have access to different medications, innovative medications, which will allow clinicians to provide care that's more personalized rather than, only having one option for most patients, or one or two options, I should say, for most patients. We'll be able to tailor our recommendations and treatments based on the type of sickle cell disease an individual experiences. And so, I'm optimistic that that will be possible. I hope that we will be able to do it in a way so that it's accessible to everyone, so that the financial costs won't preclude certain people from being able to access it, that the geography similarly won't preclude people. But I do think that in terms of where the therapies are going, we're going to be able to deliver personalized care.
Well said. Dr. Bruce?
I'm a half, my glass is very full, or more than half full, I should say. I'm hoping that we can move sickle cell to an outpatient condition, so that all the care that has to be delivered will be on an outpatient basis, so that people don't have to come into the hospital, don't have to come into emergencies anymore. That's my hope and my dream. Ideally, we'd like to get rid of it altogether, but even with the therapies coming, there will need to be some outpatient management going forward. So I don't necessarily see that happening in 20 years, but I am hoping for the vast majority of patients that everything becomes outpatient. So there is no need for those acute management, that highly distressing acute management that occurs for families and patients all the time. So that is my wish for the future. And in 20 years, I can see it happening, but I'm very Pollyanna, as some people say.
Does anybody else want to chime in on this one? Where do they see sickle cell care and management in 20-25 years? Yes, Ms. Mary?
I'll just say I'm Pollyanna a bit as well. If not in 25 years, maybe year 26, I'm looking for a cure. I want straight from newborn screening that, there's opportunities for the family to start having discussions about cure even before the first, sickle cell crisis for that baby. So that while their little bodies are still full of that protective fetal hemoglobin, that we are looking at how to help them have a normal, long life.
Thank you. That's a good one. I appreciate that. Last question. Are there efforts from industry partners to increase their presence in community to build trust? And I'll let Ms. Nikki go first, or Ms. Zoraïda, one of you.
I think I can go first.
Okay.
I have seen Novo Nordisk actually, and I can speak for Novo Nordisk only, but I've seen Novo Nordisk actually changing and having a shift towards being more committed to the rare disease space. We, for the longest time, have been known for being a big diabetes focused company, and we have also been committed to the rare disease space through hemophilia and some of the rare endocrine disorders. But since I would say 2-3 years, I have really witnessed a shift within Novo Nordisk. And when I see Novo Nordisk, not just Canada, but I'm talking about the headquarters and the people and the leadership team really investing a lot more in rare disease. One of the examples is that now we are moving into hemoglobinopathies, and sickle cell disease is one of them. We have also acquired Forma Therapeutics last year, and we really are committed to that space. So what I'm seeing is that it is starting to move from the leadership positions, and it is sometimes how it goes faster, but it also take people like me and like myself and like people that are really passionate by this topic, really to put that and have that conversation in the table, and really being able to be as close as possible. But I would say that what I've been witnessing is really predictive of being more close to the community, more invested and more committed to that space, and especially sickle cell disease, because we have now dedicated teams working on sickle cell disease specifically, whereas a year ago we only had people working in hemophilia and other rare diseases, dedicating some percentage of their time to the area. So the shift is happening. That's really predictive of more investment and more committed to the community.
Thank you so much. Anybody else want to chime in? But before we have our panelists answer more questions, I'm going to pop up the poll. Please, attendees, feel free to complete the 2-minute poll, but we will continue the conversation. Thank you.
I guess I'll answer here. From a Pfizer perspective, I think it's important. I think we've kind of talked about this throughout today, is getting the patient perspective through the life cycle of an asset. So right from discovery phase until commercialization, we are engaging patients on every level. So that's one of the things that Pfizer is doing to increase transparency, to build trust. And even internally, like with the work that we do on a day-to-day basis, we actually say something, there's a word we say trust is everything. So at Pfizer, we believe strongly that we build strong, respectful and trusting relationships with our partners inclusive of patients, that because we know that with trust, then things are moving easier. We're able to, discuss issues. We're able to work collaboratively together. We're able to move the needle forward. So I know from a Pfizer perspective that we continue to work on trusting relationships with our patient advocacy groups across Canada and even in other parts of the world, to ensure that we're doing what's right and that we're listening. I think it's always important to listen. We're always listening. So I think that's my short answer to the question. We're here, we're listening, and we really value that we work on trusted, relationships with our partners.
Thank you so much. Does anybody else want to chime in on this one? Yes, Ms. Zoraïda, you have your hand raised, or is that on hold hand?
No, I just lowered it because you gave me the mic. No, I just want to say that it also just on that point, and I'm always enjoying being in these forums, and Nikki's always there, and all the other industry partners are there. So we are really committed, as people to this space, to learning, as much as we can, to listen. I think it's really important. But I really wanted to highlight that at each, these forums, we all, as industry partners, get to see each other, learn from each other as well. And so that's also reassuring to see that, other pharma industries are also committed and interested in the space as much as we do. So just wanted to highlight that.
Thank you so much. Folks, please continue to provide your feedback into her poll. We really appreciate that. Thank you so much.
Lanre, can I just ask a quick question?
Yes, yes.
I was
Dr.
wondering what does the person who asked the question, what do you think would help develop that trust? Because like, is it awareness that people are actually involving people with sickle cell all the way through the journey of the study? Like what would help ensure or help develop the trust? Because it's an industry and patient trust was the question. And I think the best person to ask that is actually the patient representatives. How does industry develop that trust?
That's a very good question, Dr. Bro. So can the person that has this question, if you can put in the chat box or you want to raise your hand, we promote you to speak on that. But in the meantime, we can also ask either maybe Ms. Oduwole or Ms. Shereese, how do you think that trust can be developed? So the person that has the question actually responded. Sorry, before you go on, it says the doctor needs to listen to the patient more. Okay, thank you so much for that insightful feedback. Thank you. And I'm wondering if any other people on this, on this session would like to chime in and put your feedback, in the chat box. That would be great. We only have a few more minutes, but we'd like to take your feedback. And in the meantime, if either Ms. Oduwole or Ms. Maragh can also just speak to how else can we improve the trust. So somebody else already said our physicians have to listen more. So what else can we do to improve the trust?
I think it's
okay. Go ahead, Mary.
I was just going to say it's a complicated question in that it's about whole health. Every encounter that you have with your healthcare team, every time you're going on the internet to kind of look up extra information, and it's incremental. So as healthcare providers and as a healthcare delivering team, it's just very important to always remember that every encounter counts. And whatever you can do to help improve the experience with each encounter is just moving, we've been talking about moving the needle forward for that one person, to make a difference for that one person, that one patient you have in front of you. And overall, they will then have their perspective slowly shift. And then you'll see it more in terms of, the entire perspective from advocacy groups like SCAGO, hearing from people talking to them about those experiences, and then moving the needle forward for the entire, rare disease population overall. So I think for me, it's about that commitment. It's not going to take, you being positive one time or, one initiative. It's going to take everybody doing the right thing every time.
Thank you, Mary. Shereese?
Yeah, I think it's also important to recognize that everyone has their unique experience with the disease. It's not just one textbook, matter that X, Y, Z, and this is how we're going to solve it. You have to realize that other things impact each person. So as our attendee did mention, listening to the patient and really taking what they're saying into perspective when when trying to, I guess, come up with therapies or care for them.
Thank you so much for that insight. And we are at the end of today's session. It's 4:15 p.m. I want to thank our panelists. Thank you so much, Ms. Nikki from Pfizer, Ms. Zoraïda from Novo Nordisk. Thank you so much, Dr. Simpson from CHIO and Dr. Aisha from Stollery. And I want to thank so much Ms. Shereese Maragh and Ms. Mary Oduwole. I can refer to you as SCAGO volunteers as well. So thank you so much for being here and sharing your perspective. And I want to thank our amazing attendees for being part of today's session. And we thank you again, and we look forward to hosting you at SCAGO Summit 2024. Thank you. Have a wonderful rest of your weekend.